Okay. Well, hey, it's Dmitry again, and I just want to start now chapter 27 of the Guyton and Hall's Pocket Physiology again. Now, again, this is the Pocket Physiology textbook, PDF form. So if you have the actual Guyton and Hall textbook that's normal, this one's going to be a little bit more condensed, essentially. But you can follow along here, or you can follow along with your textbook in person. So, chapter 27, glomerular filtration, renal blood flow, and their control. The first step in urine formation is filtration of large amounts of fluid and solutes through the glomerular capillaries. Almost 180 liters of fluid are filtered each day. Most of this infiltrate is reabsorbed, leaving only about 1 liter of fluid to be excreted each day, although the renal excretion rate is highly variable depending on fluid intake. Composition of the glomerular filtrate. The composition of the glomerular filtrate is almost identical to that of the plasma, except that it has virtually no protein, only about 0.03%. The glomerular filtration rate, GFR, is normally about 125 milliliters over minutes, or 125 milliliters per minute, or about 20% of the renal plasma flow. Thus, the fraction of renal plasma flow that is filtered, that is to say, the filtration rate, averages about 0.2. Determinants of the GFR. The GFR is determined according to the net filtration pressure across the glomerular capillaries and the glomerular capillary filtration coefficient, Kf, which is the product of the permeability and surface area of the capillaries. GFR is equivalent to, or equals, Kf, the coefficient, times net filtration pressure. The net filtration pressure is the sum of hydrostatic and colloidosmotic forces acting across the glomerular capillaries and includes 1, the hydrostatic pressure inside the capillaries, that is, the glomerular hydrostatic pressure, Pg, which is normally about 60 mmHg and promotes filtration. 2, the hydrostatic pressure in Bowman's capsule outside of the capillaries, which is Pb, which is normally about 18 mmHg and opposes filtration. 3, the colloidosmotic pressure of the glomerular capillary plasma proteins, pi g, which averages about 32 mmHg and opposes filtration. And 4, the colloidosmotic pressure of proteins in Bowman's capsule, pi b, which is near 0 and therefore, under normal conditions, has little effect on filtration. Net filtration pressure equals Pg minus Pb minus pi b equals 10 mmHg. GFR equals Kf times, in parentheses, Pg minus Pb minus pi b, end parentheses, equaling about 125 milliliters per minute. Decreased glomerular capillary filtration coefficient, Kf, decreases GFR. Although changes in Kf have a proportionate effect on GFR, this is not a primary mechanism for physiological control of the GFR. Nevertheless, in some diseases such as uncontrolled hypertension and diabetes mellitus, GFR is reduced because of increased thickness of the glomerular capillary membrane, which reduces Kf, or because of severe damage to the capillaries and loss of capillary filtration surface area. Increased Bowman's capsule pressure decreases GFR. Changes in Bowman's capsule pressure normally does not control the GFR. However, in certain pathological states, such as urinary tract obstruction, Bowman's capsule pressure may increase to such a high level that GFR is reduced. For example, precipitation of calcium or uric acid may lead to stones that lodge in the urinary tract, often in the ureter, thereby obstructing urine flow and increasing Bowman's capsule pressure. Increased glomerular capillary colloidosmotic pressure decreases GFR. The two factors that influence glomerular capillary colloidosmotic pressure are 1, arterial colloidosmotic pressure, and 2, the fraction of plasma filtered by the glomerular capillaries, that is to say, the filtration fraction. An increase in either the arterial colloidosmotic pressure or the filtration fraction increases the glomerular capillary colloidosmotic pressure. Conversely, a decrease in arterial plasma or colloidosmotic pressure or filtration fraction reduces the glomerular colloidosmotic pressure. Because filtration fraction is the GFR/renal plasma flow ratio, a decrease in renal plasma flow increases filtration fraction. Therefore, even with constant glomerular hydrostatic pressure, decreased renal blood flow tends to increase the glomerular colloidosmotic pressure and decrease the GFR. Increased glomerular capillary hydrostatic pressure increases the GFR. That's pretty self-evident, yeah. Glomerular hydrostatic pressure is determined by three variables, each of which is physiologically regulated. Arterial pressure, increased arterial pressure tends to increase glomerular hydrostatic pressure and the GFR. However, this effect is not normally buffered by autoregulation, which minimizes the effects of blood pressure on glomerular hydrostatic pressure. Afferent arteriolar resistance increases the resistance of afferent arterioles, decreases glomerular hydrostatic pressure and GFR. Afferent arteriolar resistance. Increased afferent arteriolar resistance increases resistance to outflow of the glomerular capillaries and raises glomerular hydrostatic pressure, thereby tending to increase GFR as long as the increased afferent resistance does not reduce renal blood flow to a great extent. With severe afferent constriction, that is to say, more than a 3 to 4-fold increase in resistance, the large decrease in renal blood flow more than offsets the increase in glomerular hydrostatic pressure and reduces the GFR. And so I'm just going to go over these two graphs right here as well, showing glomerular filtration, and it shows how the glomerular filtration can, as well as the glomerular filtration is going to vary across versus the afferent arteriolar resistance, as you can see right here, and I guess also the renal blood flow. And you also can see, again, glomerular filtration right here compared to things like the afferent arteriolar resistance, and again, also the renal blood flow. Okay, here we go. Renal blood flow. Although the two kidneys constitute only about 0.4% of the total body weight, they receive a combined blood flow of about 1,100 milliliters per minute of blood flow, or about 22% of the cardiac output. A major purpose of this high flow is to supply enough plasma for the high rates of glomerular filtration that are necessary for precise regulation of body fluid volumes and solute concentrations. The mechanisms that regulate renal blood flow are therefore closely linked to those that control GFR and renal excretion. Renal blood flow is determined according to the pressure gradients across the renal vasculature and the total renal vascular resistance, as expressed by the following relation. Renal blood flow is equal to renal artery pressure minus renal vein pressure all over total renal vascular resistance. The total renal vascular resistance is the sum of the resistances of the individual vascular segments, including the arteries, arterioles, capillaries, and veins. Most of the renal vascular resistance resides in three major segments: interlobular arteries, afferent arterioles, and efferent arterioles. GFR and renal blood flow are controlled by neurohumoral systems and intrarenal mechanisms. The determinants of GFR that are most variable and most subject to physiological control include the glomerular hydrostatic pressure and the glomerular capillary colloidosmotic pressure. These pressures, in turn, are influenced by sympathetic nervous system, hormones, autocoids, vasoactive substances released by the kidneys, and other intrarenal feedback control mechanisms. Strong sympathetic nervous system activation decreases GFR. Strong activation of the sympathetic nervous system constricts the renal arterioles and decreases renal blood flow and the GFR. This effect is most important in reducing the GFR during severe, acute disturbances such as those elicited by the defense reaction, brain ischemia, or severe hemorrhage. Hormones and autocoids control the GFR and renal blood flow. Several hormones and autocoids can also influence the GFR and renal blood flow. Norepinephrine and epinephrine, which are released from the adrenal medulla, constrict afferent and efferent arterioles and decrease GFR and renal blood flow. Endothelin, a peptide released from damaged vascular endothelial cells of the kidneys and other tissues, constricts renal arterioles and decreases GFR and renal blood flow. Angiotensin II constricts efferent arterioles to a greater extent than the afferent arterioles and therefore tends to increase glomerular hydrostatic pressure while decreasing renal blood flow. Increasing angiotensin II formation usually occurs with decreased arterial pressure or volume depletion, both of which tend to reduce the GFR. In these instances, increased angiotensin II helps prevent decreases in GFR by constricting efferent arterioles. True. Very true. Endothelium-derived nitric oxide, EDNO, decreases renal vascular resistance and increases GFR and renal blood flow. EDNO, an autocoid released from vascular endothelial cells throughout the body, is important in preventing excessive vasoconstriction of the kidneys. True. Prostaglandins, especially PGE2 and PGI2, are not of major importance in regulation of the GFR and renal blood flow under normal conditions. However, prostaglandins may dampen the renal vasoconstrictor effects of sympathetic nerves or angiotensin II, especially the effects on afferent arterioles. Blockade of prostaglandin synthesis, that is to say with aspirin and non-steroidal anti-inflammatory drugs, may therefore cause significant decreases in GFR and renal blood flow, especially in patients whose extracellular fluid volume is reduced as a result of vomiting, diarrhea, dehydration, or diuretic therapy. Good to know. GFR and renal blood flow are autoregulated during changes in arterial pressure. In normal kidneys, a fall in arterial pressure to as low as 75 mmHg or a rise to as high as 160 mmHg changes GFR by only a few percent. This relative constancy of the GFR and the renal blood flow is referred to as autoregulation. Although autoregulation of the GFR and renal blood flow is not perfect, it helps prevent large changes in the GFR and therefore in renal excretion of water and solutes that would otherwise occur with changes in blood pressure. Tubuloglomerular feedback is a key component of renal autoregulation. Tubuloglomerular feedback has two parts, an afferent arteriolar mechanism and an efferent arteriolar mechanism, both of which depend on the special anatomic arrangement of the juxtaglomerular complex, the JG complex. So the JG complex consists of macula densa cells in the initial portion of the distal tubule and the JG cells in the walls of the afferent and efferent arterioles. When blood pressure is decreased, delivery of sodium chloride is decreased to the macula densa cells, which are capable of sensing this change. The decrease in sodium chloride concentration at the macula densa, in turn, causes two main effects. One, a decrease in the resistance of the afferent arterioles, which increases the glomerular hydrostatic pressure and therefore the GFR towards normal levels. And two, an increase in renin release from the JG cells of afferent and efferent arterioles, which causes increased angiotensin II formation. Angiotensin II then constricts efferent arterioles, increases arterial pressure, and increases glomerular hydrostatic pressure and GFR toward normal levels. The myogenic mechanism contributes to autoregulation of renal blood flow and the GFR. This mechanism refers to the intrinsic capability of blood vessels to constrict when blood pressure is increased. The constriction prevents the vessels from being overstretched and, by increasing vascular resistance, helps prevent excessive increase in renal blood flow and GFR when blood pressure rises. Conversely, with decreased blood pressure, the myogenic mechanism contributes to decreased vascular resistance. Okay. Okay. Other factors that alter renal blood flow and GFR. A high protein diet increases GFR and renal blood flow in part by stimulating growth of the kidneys and by reducing renal vascular resistance. Another mechanism that contributes to the effect of a high protein diet to elevate the GFR is tubuloglomerular feedback. A high protein meal increases the release of amino acids into the blood, which are reabsorbed in the proximal tubule through co-transport with sodium. This in turn causes increased proximal tubule reabsorption of amino acids, and sodium, decreased sodium chloride delivery to the macula densa, decreased afferent arteriolar resistance, and an increased GFR. Very important. You're going to probably hear this a lot. I'm going to say something and I'm going to say, oh, so true. So true. I agree. Textbook's correct. I agree with that. Yeah. Anyway, hyperglycemia, which occurs with uncontrolled diabetes mellitus, may also increase renal blood flow and GFR through tubuloglomerular feedback because glucose, like amino acids, is co-transported with sodium in the proximal tubule. Glucocorticoids increase renal blood flow and GFR by reducing renal vascular resistance. Fever increases renal blood flow and GFR by reducing renal vascular resistance. Aging decreases renal blood flow and GFR mainly because of a reduction in the number of functional nephrons. Renal blood flow and the GFR decrease about 10% during each decade of life after the age of 40 years. And that concludes chapter 27 of Guyton and Hall's Pocket Physiology. Now, again, I'm very new to this whole streaming thing, so I've been trying to work on the audio and stuff like that. I'm not sure if it's any better today than it was prior, but it's a work in progress, I guess you could say. But thank you for watching, nevertheless.